Good evening and welcome all to tonight's webinar, Managing Lymphedema, Latest Research to Improve Outcomes. And can I take this opportunity to wish you all a happy Lymphedema Awareness Month. My name is Robbie Blackwell and I will be your MC for tonight's event. Some of you might know me as I'm a lymphedema therapist and occupational therapist in our Alert Lymphedema Treatment Clinic. Tonight's webinar is presented by the Australian Lymphedema Education, Research and Treatment Program at Macquarie University. The program tonight has been tailored specifically for individuals living with lymphedema, lipedema and other chronic edemas, and health professionals helping people to manage these conditions. We're delighted to have had more than 600 people register for tonight's event. I'll now briefly outline the format for tonight's webinar. Our first presenter this evening will be Dr. Louise Kohlmeyer, who is the Director of the Alert Program and a lymphedema therapist and occupational therapist with over 30 years of clinical experience. Louise will present on latest evidence in support of implementing a prospective surveillance and early intervention model of care for cancer-related lymphedema. Louise will then introduce us to Sam, who will share her story as a person living with upper limb lymphedema. We will then hear from Brenda Gutierrez, who is also a lymphedema therapist and occupational therapist in our treatment clinic. Brenda will present on enhancing your self-management, which will be followed by a short video that highlights the patient journey when attending our ICG clinic. After our two presentations, we will hold a live Q&A session with our panel of experts. Our panel this evening will consist of our two presenters, Louise and Brenda, and will also include Dr. Helen Mackey and Professor Hiroswamy. If you have a question, please type it into the Q&A function at any point throughout tonight's webinar. We will endeavour to answer as many questions as we have time for in the Q&A session. Before I hand over to our first presenter, I will share a short welcome to country video.
Welcome. We acknowledge the traditional custodians of Macquarie University land, the Warramargal clan of the Darug Nation, whose cultures and customs have nurtured this land since the Dreamtime. We pay our respects to elders past, present and future. We welcome people of all nations and all faiths. Kwai Bidja, Jamna Payala Janawi. Come here, we speak together. We have 60,000 years of archaeological evidence of Aboriginal habitation at Lake Mungo and 20,000 years in Ryde. We have great antiquity. Today, hundreds of Aboriginal and Torres Strait Islander people graduate from Macquarie University. The Darug Nation had famous leaders such as Chief Yarramundi, Naraginji, Colby and Maria Locke. Many of the descendants of these Darug people live today amongst you. We celebrate with you our ongoing attachment and custodianship with this country. We celebrate the achievements of Macquarie University.
I will now pass over to Louise Kohlmeyer, our first presenter this evening.
Good evening, everyone, and fantastic to have such a wonderful response to participate in this Alert webinar to celebrate Lymphedema Awareness Month. Many thanks, Robbie, for the introduction and welcome. It gives me great pleasure to be able to share with you this evening the results of some latest research in breast cancer-related lymphedema, which is very dear to my heart and that we have been working here at Macquarie University on for the last 7 years. This research has recently been published in a scientific journal, Lymphatic Research and Biology, and is available to freely download. Even if you have lymphedema from another cause, I hope that you will see the benefits of this research and how it translates to all individuals at risk of or living with all types and stages of lymphedema. At the conclusion of my presentation, I would like you all to be able to describe the components of a prospective surveillance and early intervention model of care in cancer rehabilitation. I'd like you to be able to describe why this model should be adopted in breast cancer care and other cancer care as well. Describe the primary aim results of the PREVENT clinical trial and describe how to advocate for and educate the community about the importance of this model of care to improve outcomes for individuals. This is the condition we're all here about tonight, lymphedema. We all know that lymphedema is a survivorship issue associated with cancer treatment, and it can be often be the daily reminder of an individual having had cancer. We know that lymphedema may impact an individual not only physically, but functionally, psychologically, and financially. Lymphedema may lead to pain, to heaviness, possible infection or cellulitis, and also costly therapy, and can impact an individual's ability to work and care for themselves and their family. With continuing improvement in cancer survivorship, long-term patient quality of life has grown in importance. Lymphedema incidence rates range from 5% to 50%, depending on cancer treatment. We know, however, that increasing use of post-mastectomy radiotherapy and also regional nodal treatment is refueling a resurgence of lymphedema. So, what is a prospective surveillance and early intervention model of care in cancer rehabilitation? Prospective surveillance aims to detect subclinical, known as stage 0 or early stage 1 lymphedema. Early intervention is more easily managed than later stage lymphedema and is potentially reversible. Early intervention also aims to prevent progression to chronic or late stage lymphedema. All individuals at risk of lymphedema should have access to a prospective surveillance and early intervention model of care in all healthcare settings. And collaborative multidisciplinary cancer teams should aim to adopt this model of care with appropriate monitoring protocol, education, and early intervention clinical pathways in place. So why should we adopt a prospective surveillance and early intervention model of care in cancer rehabilitation? Prior studies suggest that early detection of subclinical lymphedema combined with immediate short-term compression therapy can prevent chronic cancer-related lymphedema. As you can see on this slide, there's been a significant growing evidence over the last decade internationally that supports this model of care. And these key organisations have all developed key position statements and protocols on prospective surveillance and early intervention. In many ways, they recommend routine monitoring from time of breast cancer diagnosis and ongoing education and rehabilitation according to an individual's risk. So now I'd like to share with you the results of an international randomized controlled trial known as the PREVENT study. I'd like to acknowledge my local and international colleagues who have supported this important work. A special thanks go to Professor John Boyages, my co-principal investigator for the Australian sites, to Katrina Gaitatsis, our PREVENT study coordinator, and the many alert team members who were research assistants who worked tirelessly and on this study, as well as the medical and administration teams at the 4 hospitals where we conducted the study here in Australia. They were Macquarie University Hospital, here where I am tonight, Westmead Public Hospital, Norwest Private Hospital, and the Sydney Adventist Hospital. This study was funded by the National Institute of Health in the United States with support from ImpediMed and Medi. These are the 10 sites internationally that were involved in the study. I'd like to say a special, sincere thank you to the 450 women who voluntarily participated in the study through Macquarie University, and also the other hundreds of women who participated internationally. You trusted us as investigators to complete this work, and we are very grateful. And there may be some of you who participated in this PREVENT study joining us this evening. So the primary aim of the PREVENT study was to determine if subclinical detection of extracellular fluid accumulation via bioimpedance spectroscopy, or BIS as I will now call it, and subsequent early intervention, whether it reduces the rate of progression to complex lymphedema therapy relative to rates seen using the standard volume tape measurements. The inclusion and exclusion criteria are listed on the slides. We had 2 stages of inclusion into the study. The first stage was when an individual was diagnosed with breast cancer prior to any surgery. And there was a second stage of inclusion criteria for following surgery at the post-surgical appointment. You will see there was exclusion criteria, and we were very set and structured in who this study was available for to try to optimize the risk levels of those in the study to maximize the long-term results. These are the 2 assessment methods that were used in the PREVENT study. So on the left, we have bioimpedance spectroscopy. As part of the study, we used a U400 device. Many of you may be aware of the SOZO device, which is the latest whiz-bang bioimpedance spectroscopy device. But I just put a photo here so you can see what device was used throughout the study, which is the same technology as some of you may be aware of with the SOZO device. This measures impedance at 256 frequencies up to 1,000 kilohertz. Bioimpedance spectroscopy detects changes in fluid as small as 35 milliliters, and it compares the at-risk or affected side to the unaffected limb. The BIS technology has been validated internationally with lymphoscintigraphy, one of the gold standards in measuring for lymphedema. And as many of you may know, the BIS gives us an LDEX score. The LDEX score's normal range is between -10 and +10. An LDEX score change of 6.5 from a pre-treatment baseline reading is 80% sensitive and 90% specific in detecting subclinical lymphedema. Now on the right, we have the good old tape measure, almost a badge of honor as a lymphedema therapist. I think I had 5 tape measures in my handbag when I used to travel, just in case, you never know when you might need one. So the tape measure is a very user-friendly measurement technique. The technique was used in this study as an optimal technique to ensure consistent results could be obtained to minimize risk of lymphedema progression. The tape measure protocol that was used, measurements were taken at 10 centimetre intervals with a minimum of 5 measurements per arm. The measuring board that you can see on this photo was made specifically for the study, and it was made to ensure repeatability so that every single patient that was included in the study undergoing circumference measurements with the tape measure was used in this set protocol. We used a Gulick 2 tape measure with springs to ensure consistent tension during every measurement. Each arm was measured twice, and each clinical site was trained annually by the study principal investigator, Dr. Sheila Reidner, as well as ongoing local training for each site throughout the year. So this is a diagram, a flow chart of the study design. We actually considered 1,239 individuals for enrolment between June 2014 and September 2018. We enrolled 1,200 women pre-surgical baseline. A few of these women were unable to meet all of the criteria in the two-stage enrolment process. So we had, in the final analysis, tape measure patients, we had 437, and BIS LDEX patients in the group 442. So they were very evenly spread groups. You can see here that the design of the study was an individual had a pre-treatment baseline measure. They had both LDEX and volume tape measurements taken. They had to have had a histologically confirmed breast cancer and that were having planned surgery. After surgery, they came back for randomization into the two arms of the group, either tape measure or BIS, and they had to at least have one of the following, either a mastectomy, axillary treatment, either an axillary lymph node dissection or sentinel lymph node biopsy with greater than 6 lymph nodes removed, axillary radiation, or taxane-based chemotherapy. Then they went into their two separate randomized groups with LDEX monitoring or tape measure monitoring for the period down below of intervals over a 3-year period. So they were followed up at 3, 6, 12, 15, 18, 21, 24, 30, and 36 months. The 15 and 21 month were optional, but majority of people did undertake those measurements. Now for the LDEX group, if at any of those monitoring periods, they triggered a greater than 6.5 change in LDEX from baseline, they were then referred for intervention. Likewise, in the tape measure group, if they triggered a greater than 5 and less than 10% change in volume from baseline, that determined that they needed early intervention. So the intervention included a compression sleeve and gauntlet, which was worn for 4 weeks, 12 hours per day. If any individuals had a greater than 10% volume change, then they were actually exited from the study and because they progressed to CLT. Remember, we were looking at early subclinical lymphedema that we were trying to reduce from this study. Then post-intervention, after the 28 days of wearing the compression sleeve, they were followed up ongoingly for using a tape measure. So both groups after intervention used the tape measure. If they maintained a less than 10% volume difference from baseline, knowing that the 10% is usually indicated as clinical lymphedema, then they were continued to be monitored for the ongoing time in the 3-year monitoring period. If they ever had an increase in greater than 10% volume difference from their baseline, then they progressed to CLT and were outside of the study. And CLT, for those who may not be aware of that jargon, complex lymphedema therapy. So the individual was referred to a lymphedema therapist for intensive therapy to try to reduce that volume difference. So the results of the study can be seen in the next few slides. You can see that the median age for women in both groups, and I have to say that all individuals participating in the study were women. The median age was 58 years for both groups, and you can see there they had the same spread of cancer across the two groups. So you have the tape measure group and the LDEX group. And we were evaluating 437 women in the tape measure group, 442 in the LDEX group. But we looked at DCIS, ductal carcinoma in situ, and stage 1, 2, and 3 breast cancer. And you can see that the two groups were very similar in the stages of breast cancer randomized to each group. Likewise, the BMI of the two groups was very similar and not statistically significant. Again, this slide shows that there were also no differences in treatment of the two groups. So women in each group, there was no statistical difference between the BIS and the tape measure group for any of the treatment-related factors. So the type of surgery, axillary versus sentinel node biopsy, whether it was conservative surgery or mastectomy, chemotherapy or radiotherapy, the two groups were very well balanced across treatment factors and demographic factors. As I mentioned, the study intervention for the 4-week period was wearing a compression sleeve, with a Medi-Harmony sleeve, 23 to 32 millimeters of mercury, sleeve and gauntlet. And the individual was educated in wearing the sleeve and gauntlet 12 hours per day for 4 weeks. And then they returned to be reviewed by the research team. Now, I guess this is the slide with the primary outcome results. And you'll see I've got the two key findings highlighted with a star. A lower proportion of BIS patients triggered an intervention. Here you'll see 120 women triggered intervention in the tape measure group out of 437, and 89 triggered intervention in the LDEX group out of 442 women. And the median months from randomization to intervention triggering were longer in the BIS group than the tape measure group. And I'm sure as you'll digest these findings, I'm sure there'll be questions that you'll have for me, and I look forward to those. Following the early intervention period, patients in the BIS group were less likely to progress to complex lymphedema therapy than those in the tape measure group, which is what we've been saying, but it's really nice to have some hardcore data showing us that baseline measurements, regular monitoring, early intervention, bringing the patient on board with you is achieving earlier results and less progression to chronic long-term lymphedema. So what can we all do to promote the implementation of this model of care now that we've got some good data that highlights and shows that this is what we should be doing? We should be out there getting this message out to the community. We should be advocating for all individuals at risk of lymphedema to have access to a prospective surveillance and early intervention model of care. We should educate members of cancer multidisciplinary teams and GPs to be aware of the latest research. It often takes years before research published in scientific journals is standard of care. We need to fasten this process. We need to educate family, friends, and the community networks of early detection and early intervention to reduce the long-term effects of lymphedema. And we should also advocate for increased public funding for lymphedema treatment. We need to advocate to get a lymphedema Medicare item code, and also advocate for national equity for lymphedema access to compression garments. The PREVENT study highlighted that these statistically significant results demonstrate that bioimpedance spectroscopy screening should be a standard approach for prospective breast cancer-related lymphedema surveillance. This is more specific for lymphedema detection than tape measure, as it had fewer triggers and longer times to intervention trigger. This, as compared to tape measure, provides a more precise identification of patients likely to benefit from an early compression intervention. And this model of care should be translated to all cancer groups so that all individuals going through cancer treatment and at risk of lymphedema have access to this model. So thank you for listening, and I really look forward to further discussions during the Q&A session, and I invite you to put questions in the Q&A as you think of them. I'd like to now move on and introduce you to one of our wonderful patients, Samantha Guthrie, who spent time with our team to share her lymphedema story. So I'm going to play Sam's video and just reflect on what she's saying about her experiences of living with lymphedema that may or may not be similar to yours. Thanks, Sam.
I was diagnosed with breast cancer in 2015. I had a lump under my arm, and so my initial surgery was an axilla node clearance where they got rid of 19 of my lymph nodes, and then I went on to have chemotherapy with paclitaxel and adriamycin, and then radiation. So all three of those things really contributed to my lymphedema. I do sometimes wear my garment, probably not as much as prescribed, but I do try to wear it as much as I can. I also really love swimming, so I'm swimming 5 to 6 times a week now, 2 times a week in the pool and the rest of the time in the ocean. So I've really noticed a big improvement to my lymphedema since doing that much swimming during the week. I have a pump at home, and when I'm feeling particularly stressed or noticing that there is a bit of fullness in my arm, I will put that pump on, and the program goes for 30 minutes. So I'm probably using that twice a month, so not very often, but it does make a difference in just making it feel a bit softer and not as full and heavy. Lymphedema was unexpected for me. So when I was going through all of the cancer treatment, it was something that was mentioned but not really talked about in great detail. I was just told there was a risk of lymphedema, and with everything else going on, I didn't really think too much about it. So once I got towards the end of my treatment, I'd started to travel and was going in airplanes, and so I got some garments. And that's when I really started to notice A, the lymphedema coming on, and B, the impact of life with lymphedema. So one of the first things I noticed was that feeling of fullness and feeling that your arm isn't really working the way that it should. I'm left-handed, so it's on my left arm, so when I'm wearing my garments, I find it quite hard to write. And I work full-time doing a lot of writing, so that impacts me. And also it's the feeling of being looked at as well. So the main reason that I don't wear my garment is not because it's not comfortable, but because it's actually very obvious to people. I've tried the black colour as well, and that's still quite obvious. Everyone when they see it, asks what's wrong. Even people that I work with regularly and know that I have lymphedema will ask. And so I find that a really yuck reminder of having cancer, and the fact that my arm will never be the same again. It will never return to complete strength and mobility. So I find that probably the most annoying part of having lymphedema. It also makes it hard to have photos as well, so I always turn on the left side so you can't see my arm. So it's an embarrassing visual thing that you do notice. Yeah. So I have a 7-year-old, and so she was 2.5 when I was diagnosed, and having lymphedema does make it a little bit hard to manage. Well, I think managing a 7-year-old is hard anyway, but I have found it challenging for her. She knows that mummy has a sore arm and that she can't lie on it because it gets uncomfortable, and that she has to be very careful to not scratch it or do any skin damage to it. So she's aware that I have lymphedema and that we have to be careful of mummy's arm. So yeah, that's another challenge. I can't enjoy a warm bath. I do, you can feel it swelling really quickly if you get into hot water, like a hot tub or something like that. Apart from that, it's not that I can't do anything, it's just that things are a bit different. So whilst I love my swimming, my swim stroke has really changed post having lymphedema. So I think it's a combination of lymphedema and other aspects of my treatment. So I do have a lot of scar tissue from radiation and surgery, but my left arm is no longer my dominant arm when I swim. So that's completely changed the way I swim, and it's put a lot of pressure on my non-dominant arm. So I now have a recurring shoulder impingement, I guess is what you'd call it. It's not an injury yet, but it probably will be down the track the more and more I swim and the more I use this arm rather than using both arms equally. So it does make a difference. I had never considered lymphedema when buying clothes. It's only when I started to buy things like a denim jacket or non-stretchy material that I really noticed that the difference in volume, whilst it doesn't look like a lot, does actually make a difference when you're buying clothes like that. It makes it quite uncomfortable. And that's just another reminder every day you put that jacket on that you've got lymphedema, and maybe it's not a good day today because it's hard to get the jacket on. So maybe it's wear something stretchy and make sure you use your pump. So there's always a reminder in some way of lymphedema. And I guess the other thing for me that's a constant reminder is having lymphedema in my left dominant arm. It means that all of my blood tests and all that sort of thing have to be done on my right arm, including all of my chemo. So I'm now very troublesome when people need to take blood from me because they can't use my lymphedema arm. They have to use the destroyed right arm instead. So that's just another fun joy of living with lymphedema. I can only speak from someone who's had the cancer aspect first, so I can't imagine what it's like having primary lymphedema. But I guess what I'd want them to know is that it may not sound like a big deal, but it's a huge deal, and it has forever impact on a person's life once they've developed it. So anything you can do to stop it or aggressively treat it when it's early, then talk to your patient about that, because chances are they'll be willing to do what it is that you're suggesting. I think the other thing is to not think that it's a minor impact on people's lives. Like it's a reminder for me every time I wear my sleeve that I've had cancer, And it's not just a reminder because I can feel the sleeve, but it's a reminder because everyone's asking why I'm wearing it. So just be cognizant of that. It is a big impact on people's lives, and it really can be quite a demoralising disease, I guess, to live with. So be compassionate and be aggressive early would be my suggestion, because I think that's what I would have liked as a patient. Yeah. So when I was initially diagnosed with cancer, and I underwent surgery about 3 weeks after initial diagnosis, I was given a pamphlet about lymphedema and was told that I had a fairly low chance of developing it. And so I didn't really think much about it at all. And in hindsight, I wish I had known a bit more about lymphedema and the potential risks, because looking back now, I had an axilla node clearance. So that really is quite a risky procedure for developing it. I also am prone to immune responses, whether it be skin rash, etc. So, you know, all those things did increase my risk. So I wish I'd known a bit more a bit earlier, so I could have done some more things to perhaps prevent it, or at least reduce it a little bit better than I did. I also found that when I did investigate a bit further, so I went to a free information seminar at the place I was treated for cancer, and they measured me for a garment and helped me with massage, but really didn't give me any helpful tips on managing what was quite a distressing disease for me. I didn't want to look at my arm, I didn't want to touch my arm, but yet I was being told to massage it every day. That to me I found really quite frustrating, and also almost futile. I didn't feel like there were many options for me. So it's only by chance and by Googling that I found where I'm currently treated now here at Alert, and that has made a huge difference. It's brought my arm right down. I feel like I've got a bit more control about what I can do and what helps and what doesn't help. And I just feel like the people that are treating me know more about lymphedema and are treating based on evidence rather than just the soft massaging that really didn't make a difference to me. So I'm glad I'm here. I've been to a few therapists here. They're all very knowledgeable and very research based. So they're looking at me as a whole person rather than just my lymphedema arm. So it was really here that I understood the full impact of my other cancer treatments on lymphedema. I thought it was just my axilla node clearance that had caused it, but really the radiation damage that I have on my left side of my torso even has made an impact on my lymphedema. So being able to treat that and looking at that and thinking about that has really helped me feel like there's more I can do. I can feel if I'm tight on my side now, and I know that I need to get treatment. I also feel that talking to people here, they have done the research, and so they know more than what was known, say, 40 or 50 years ago, which seems to be the current thinking in other places, which is quite scary. But also just the therapeutic tools like the ICG. So I had an ICG done here, and it really has formed my treatment path as well. So when I do get a massage, it's a massage informed by evidence. So they know where to push the fluid and it clears it so much more quickly and for a longer lasting result. So I really do feel like I'm actually doing something proactive and practical here, whereas in other places I felt like it's much more of a passive, almost just wait until it gets worse and then the next step is something more drastic. And so I feel like I can be a bit more proactive and aggressive in treating it and making sure it doesn't get worse and that it doesn't impact my life further than it already has. Yeah.
Okay, so hi everyone, and welcome. Lovely to see you all, to know you're all here. I wanted to say firstly thank you to Sam for sharing her experiences with lymphedema and her insights into living with this condition. I know there are a couple of comments coming up on the chat to say that they're really resonating with a lot of what she's saying, and I think everyone has a unique experience, but it's certainly nice to hear some shared experiences there too. And of course, thank you to Louise for your presentation, and congratulations to your team on completing your study. It's just great to have such high quality research being done into lymphedema. And we look forward to this becoming really the standard of care moving into the future. So thank you. So the focus of my presentation, persuade this to change slides. There we go. Okay, so the focus of my presentation tonight is enhancing self-management of lymphedema. However, before getting into practicalities, I'd like to explore a bit more the nature of self-management and the nature of chronic conditions. So firstly, I'd like to ask you what you see as being self-management. What comes to mind when you hear this term? So I'm expecting most of you would come up with a list similar to this one. So wearing a garment, exercising, self-management, self-massage, using a pump, maybe skincare. So self-management being the everyday things that a person with lymphedema does to best manage their condition. If we widen our perspective though, self-management or self-care can embrace a more comprehensive approach to health. The World Health Organization defines self-care broadly as the ability of individuals, families and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without that support of a healthcare provider. So with this expanded definition, we can think of some of the other broader tasks that come with a diagnosis of lymphedema, such as even just getting a diagnosis, understanding lymphedema and its management, finding or changing your healthcare professionals, making regular appointments, updating your garments, dealing with changes in your condition, adjusting to other health issues, connecting with others, as Louise already mentioned, lobbying for improved services, and a whole host of other things. And as you know, lymphedema doesn't happen in a vacuum. Secondary lymphedema, like Sam was sharing, often occurs after cancer treatment, perhaps once you've moved into that survivorship phase and are ready to put cancer behind you. In my work, I hear lots of stories about busy and demanding jobs, busy family life, a precious new grandbaby arriving, time split between hobbies, friends and family, and of course some complex and often difficult circumstances. All of these are plenty to fill our lives, and then there's lymphedema in amongst everything else. Now, lymphedema, of course, is a chronic condition. So it's a long-term condition. And by definition, the goal is for management, not for cure. This in itself is quite a challenge. Questions, especially in the early days, tend to be, so this is permanent, this is the way it's always going to be. Isn't there a medication or some type of operation to fix my lymph system? It's a lot to accept and to adjust to. And of course, managing lymphedema, it's not a sprint, we're in for the long haul. In 2017, so 5 years ago already, the Council of the Australian Governments released their framework document for chronic conditions. In this, the vision was stated as being for all Australians to live healthier lives through effective prevention and management of chronic conditions. It's certainly pleasing to see that chronic conditions are being recognised more as a focus in health policy. This is the top 10, if you like, chronic conditions that are brought to the fore by this framework. As you can see, lymphedema isn't there, but cancer is, where it's acknowledged as a chronic condition that does require ongoing management. There's a few others there that perhaps you're looking at and saying, oh, yes, 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 I'm seeing those too. And there are some interesting statistics that came with this framework. So did you know, for example, that according to data used in the most recent census, 1 in every 2 Australians is considered to have a chronic condition, and 1 in 5 Australians have 2 or more chronic conditions, which is really quite mind-blowing. And not surprisingly, the risk of having more than one chronic condition increases with age. And consider also that effort and mental load that comes with managing your condition or conditions. In the research and also in the framework document, it's acknowledged that care for chronic conditions is often fragmented. That is, you're usually receiving care from different and unconnected healthcare providers. This may mean that you're summarising, prioritising, explaining, and conveying information from one provider to another about your own care or the care of someone or someone you're supporting. Priorities often shift also between lymphedema and other health conditions. So I say it's a little bit like an ebb and flow, or a bit like the tide coming in and out. Sometimes lymphedema is your focus, other times it's something else. So my intention in highlighting these is not to discourage, but to acknowledge what a challenging job you're all doing in managing your health, including your lymphedema. So when we're talking about self-management of lymphedema, anything that we do should be effective and therefore worth your time, enough, so not too little, not too much. It needs to be balanced. So considering the many facets to your life, and also sustainable, because we're talking here about a lifelong condition. So now that I've given that background, let's talk about some practical steps about caring for your lymphedema. So I've been working in lymphedema since the 90s, which is a little bit of a scary thought, really. Don't know where that time's gone. And whilst there have been many changes and many exciting new developments, the 4 main areas of lymphedema management have remained the same. So these are compression, manual lymphatic drainage, exercise, and skincare. I'm going to talk a little bit about each of those now. So compression. This is one of the most important areas of lymphedema self-management, and the one that we have the strongest evidence for. Most of my people wear compression most of the time, usually during the day and sometimes also overnight. And that best practice for established lymphedema is using flat knit, custom-made compression garments. And as you all know, they can't do their work unless you wear them. I hear you. Yes, they can be thick, they can be warm, they can be tricky and time-consuming to get on. And yes, they're expensive, especially when you need 2 sets at least and need to update them every 6 months. Working backwards, regarding the expense of garments, the good news is that all states in Australia now have compression schemes, compression garment schemes. So these schemes have been brought in so that people with lymphedema don't need to compromise their lymphedema management with garments as a result of their cost. The schemes do have fairly strict eligibility criteria, and not everyone with lymphedema is eligible in every state, but they're absolutely worthwhile pursuing. So they're all accessed through your lymphedema therapist. So if you haven't already, have a conversation with them about accessing your local funding scheme. The scheme in New South Wales is Enable New South Wales, and it does provide support towards the purchase of 2 sets of garments per body part every 6 months and is open to anyone with lymphedema. By way of encouragement, I'm yet to have a request declined for someone needing flat knit custom-made compression garments. As an alternative though, of course, it's worthwhile making inquiries through your private health fund. And it's a good idea, I usually say, to call twice because not all staff at the health fund will understand lymphedema. Now, in regards to getting the dash things on, there are donning aids to help get garments on. So I would encourage you to have a talk with your therapist and explore what options there are. And of course, your textured rubber gloves, either like your HyFlex from Ansell or your Ansell pink washing up gloves with the texture on the fingers, they really do make a difference in being able to grip your garment. Most of my people tell me they need to make extra time in the morning to get their garments on. It is one of those things that cannot be rushed. The garments are thick, yes, but that's by design. And it is a feature that works in your favour. The nature of the fabric means that it doesn't roll as much and it doesn't fold into those knife-like creases, and it holds or pushes back against that edema, which is what you want. You don't want to be accommodating that swelling. And yes, as an extra layer, they are warm, although not as warm as they look, or so I'm told. Most people I've spoken about garments are fairly pragmatic. You know, the garments are there for a purpose. They're an important tool in managing lymphedema, and they adapt. But definitely keep that conversation going with your therapist. And if your needs are changing, your garments may well need to be updated. Okay, the second is manual lymphatic drainage. Now, this is a tool that has undergone huge changes in recent years. Our original theories on how and why this technique helps with lymphedema have been challenged, and they have been updated. From our indocyanine green imaging, or ICG, which Sam also spoke about, we have a much clearer picture on what effect we can have on lymphatic movement by using manual lymphatic drainage. It has revolutionised our clinical practice. Through observing and assessing a wide range of people in our diagnostic clinic, we've identified some trends in drainage patterns which help inform our recommendations. We now know, for example, that if there is what we call dermal backflow, where the lymph fluid is not moving quickly through a lymphatic collector in the limb, but instead is moving through the finer lymphatic capillaries, that a firm stroke is needed in order to have an effect. And it was interesting, even just today, I had a patient who I had shown how to do the updated massage, and she was passing that information on to one of her doctors in her healthcare team. The next section of this webinar will be showing one person's journey through the ICG process, and it is actually quite a clear reflection on what actually happens in the diagnostic clinic. And I'd encourage anyone who's struggling with their lymphedema or wishes to better understand how their individual system is working to consider attending the diagnostic clinic at MQ Health Lymphedema. We are fortunate, and looking at the picture here, we're fortunate also to have available sequential intermittent pneumatic compression devices, or pumps, it's much easier to say. These can be a helpful option as part of your lymphedema self-management. The pump program often takes about an hour, which I've had various responses to. One person was outraged, protesting that I don't have an hour free simply to sit around, whilst others have reported how much they appreciate having the time set aside to care for their health and their well-being. And you know what? They're both right. Now, the next area is skincare. Now, your skin is your body's largest system and is closely connected to your lymph system. If one struggles, so does the other. So looking after your skin helps minimise the load on your lymph system. Moisture really is your friend, and so is a balanced and healthy diet. Your skin cannot be healthy without both of these. So traditionally, we've told people to use a bland moisturiser, something without perfume, which can act as an irritant, and without vitamin E if they're using it under compression garments, because it can perish the garments. We also now know that there are some key ingredients that are worth looking out for when you're choosing your skincare products. And so these ingredients are glycerol, hyaluronic acid, glycerin, ceramide and paraffin. And especially the glycerin and the paraffin work together really well. There are also some ingredients to avoid, and to me it's fabulous to have this information. So they do recommend avoiding parabens, fragrances, which we also mentioned, your sodium lauryl sulfate, so there's your foaming agents, and also lanolin. We know, getting back to skincare too, there's never a completely convenient time to moisturise, but most people do find straight after the shower in the morning and just before bed seem to be the times that work best. Okay, now exercise. As an overarching rule, whatever your physical activities levels are at present, you should be aiming to do a little bit more. We want you to move every day. We want you to avoid inactivity and of course build up gradually and carry out a combination of aerobic and resistive exercises. Now this is something you may need to approach your healthcare provider about and get some extra guidance on, depending on your health. But we're talking about a combination of physical activity. We're looking at aerobic exercise, which is things like going for a walk, going for a jog or a bike ride, playing sports such as soccer or tennis, or going swimming. Hydrotherapy is fabulous. Doing a class either at a gym or following a YouTube video. And also your resistive exercise. This is where you're using hand weights, resistance bands, but even at a more simple way, doing a sit to stand, but maintaining form, making sure that you're controlling your movements there. Or setting yourself a challenge, go up and down some stairs. Speaking with an exercise physiologist, she's a big fan of stairs. She said everyone has them and you should be using them to work on that skeletal muscle. Finally, some practical considerations. Bringing it all together, I'd encourage you to think about how you're organising yourself and your information as part of your self-management. Are your systems working? And if they are, fabulous, well done. Your system doesn't need to be perfect, but it does need to work well for you. It may be pieces of paper taped onto the wall. It may be, everything with bells and whistles and electronically scanned. That's fine as well, or anything in between. But keep in mind that some systems work really well at first when things are simple, but as time goes on and things get more complex, sometimes you do need to revisit that system and make sure it's working well for you. So make some time to polish up your systems and perhaps start a new one. So in conclusion, self-management, as I said at the start, are the everyday things that a person with lymphedema does in order to best manage their condition. This not only includes lymphedema-specific tasks, but also balancing these with managing the many other aspects of your lifestyle. So be organised, be kind to yourself, and remember you're in for the long haul. Now I'd like to share the video with you.
Hello, my name is Louise Kohlmeyer and I'm the Director of the ALERT program at Macquarie University. ALERT stands for the Australian Lymphedema Education, Research and Treatment Program. The ALERT program is a multidisciplinary program offering personalised care in treatment, evidence-based education for health professionals and consumers, and innovative clinical research in all aspects of lymphedema, lipedema, and other chronic edemas. At the ALERT program, we hold a diagnostic clinic on a weekly basis exploring indocyanine green lymphography, known as ICG. In the ICG clinic, we actually explore in real time what is happening to the lymphatic vessels and whether there's any damage or deficiency in how the vessels are functioning. Today we're going to take on the journey with Sophie, one of our patients, and see what happens within this multidisciplinary clinic. As Sophie walks into our clinic, she is welcomed by our friendly reception staff who complete all necessary referral information and clinic registration. Sophie then has objective measurements taken by members of our research team. These measurements include volumetric measurements taken with a tape measure or pyrometer and bioimpedance spectroscopy, known as LDEX, and body composition measurements taken on the SOZO device. Sophie is then assessed by Dr. Helen Macquarie, our lymphedema medical specialist, where she takes a full medical review and history and assesses her condition. Dr. Macquarie completes the pitting test, assesses Sophie's skin condition, and answers any questions that Sophie may have about her condition or possible treatments. Dr. Macquarie then formally consents Sophie for the ICG imaging investigation. Sophie then enters our ICG room where our state-of-the-art equipment is located, and she is injected with the ICG dye as per our alert published protocol by Dr. Helen Macquarie. The ICG mapping takes approximately 1 to 1.5 hours, and our lymphatic anatomy expert, Associate Professor Hiro Swami, operates the camera and images the limb. The initial observation period lasts for about 20 minutes, and after this, our experienced lymphedema therapist, Robbie Blackwell, commences manual lymphatic drainage massage to help facilitate movement of the dye. Generally, by the end of the mapping procedure, we have a greater understanding of whether a diagnosis of lymphedema is confirmed or excluded, the structure of the lymphatic system and visibility of how Sophie's lymphatic system is compensating to try to maintain fluid homeostasis, areas of dermal backflow and areas with functional lymphatic collector vessels are shown. The ICG also shows which set or sets of regional lymph nodes the fluid is draining to, and if there is more than one pathway, which pathway is dominant. This may include the identification of entry points to the deep lymphatics. Robbie then has a one-on-one consultation with Sophie to discuss her own ICG results and discuss her personalised mapping plan and treatment options available. The ICG provides an excellent opportunity for helping to educate Sophie on what is happening in her body and the relevance of the different interventions that we recommend for the management of this condition, such as compression garments and pneumatic compression pump. This is often empowering for individuals, as frequently their understanding of this condition is limited prior to doing the ICG. The final part of the process in our diagnostic clinic is the development and coordination of the patient's ICG report. The report is completed by the members of the team during Sophie's assessment at the Alert Clinic. The report summarises everything that has been assessed, observed and discovered while Sophie is with us, and provides personalised recommendations based on both ICG findings and international best practice to improve patient outcomes. When this report is read by Sophie or her local therapist or doctor, it is hugely beneficial to those people to understand the concepts and terminology used and to know how to interpret the diagrams and charts that accompany the summary letter. Sophie feels very grateful for all of the information she has been given in the clinic today and is feeling positive about managing her lymphedema using this information from the ICG assessment.
So I'm going to turn off my share. Sorry.
Okay. Thanks, Brenda.
There's the button. Sorry about that.
So a big thank you to all of our presenters this evening. I hope you will enjoy the short clip we finished with, outlining the ICG journey through our diagnostic clinic. At Alert, we are passionate about sharing our ICG research with health professionals, both here in Australia and internationally, so that people living with lymphedema, lipedema, and other chronic edemas can benefit from what we are learning from our use of ICG lymphography, as we appreciate that not everyone has access to having an ICG themselves. We've incorporated this research and its implications on the assessment and treatment of people living with these conditions into an online learning package that can be accessed by health professionals from anywhere in the world. We would invite and encourage any health professionals interested in learning more about how ICG can guide clinical practice to consider enrolling and completing this unit of study that is now being offered through Alert and Macquarie University. The unit of study is called Contemporary Evidence for Advanced Practitioners, and more information is available by making contact with the Alert education team. We're now going to move on to the next part of tonight's program, our live Q&A session. Thank you to everybody that has already posted their questions, and we'd invite anyone with outstanding questions to please post now through the Q&A function in Zoom. Okay. So I invite the panel now to join me, and what we'll do is I'm going to read through the questions. If we don't have time to get to your question, I do apologise. What we'll be doing is collating any outstanding questions and circulating answers at the completion or over the next week or so. Okay, so first question. It's a good question, and actually, Dr. Helen Mackie, we might ask if you wouldn't mind commenting on this question. What's being done to help people with primary lymphedema?
So the ICG is used probably now as much for people with primary lymphedema as in cancer-related lymphedema. So primary lymphedema mainly affects, can you hear me? Primary lymphedema mainly affects the lower limb, and we have published now information relating and comparing primary lymphodemas to the secondary lymphodemas. I've identified some of the patterns which we see in primary lymphedema, and really hopefully we'll be able to provide, I've actually just finished MRES on primary lymphedema, so hopefully we'll be able to bring to the lymphedema community, particularly those with primary lymphedema, some of this patterns and information relating to primary lymphedema. So although cancer-related lymphedema has a start and an understanding, primary lymphedema is often quite a distressing diagnosis for people to have, and giving again information, feedback, understanding of what's going on in the limb in primary lymphedema is really, really important.
And can I add there, Robbie, I totally agree with what Dr. Mackie has said. Helen is our guru, the most knowledgeable medical practitioner in the country, and certainly primary lymphedema, there's a long way that we still need to develop research in. But I think often individuals with primary lymphedema do feel like there's always more happening in the research area and evidence in the cancer-related lymphedema. And you're probably correct in that observation. A lot of the research and resources and funding often comes in the survivorship area for secondary lymphedema to cancer. But I actually look at that as a positive thing for our primary lymphedema patients, because we can actually often translate a lot of the research outcomes from our secondary lymphedema into our primary lymphedema population. So please feel like, you know, some of the work that's happening in secondary lymphedema is going to help those with primary lymphedema. And we need to, again, lobby for increased funding for access to research in the more smaller markets.
Thanks, Dr. Mackie and Dr. Kohlmeyer. Now, our next question, we might move on to actually another question for you, Louise, on early intervention. So we've had a few questions, similar questions from a few different people asking about setting up an early intervention model in public hospitals or any hospital for that matter. I wonder if you can give us some tips or hints for any therapists looking to embark on that journey.
Sure, thanks, Robbie. I encourage all lymphedema therapists to work in this early intervention area. And I think if we don't work in that area, we're going to miss the boat. And most of my patients these days are a lot more in the early intervention area. We do run education workshops on establishing and implementing an early intervention model of care. In New South Wales Health, for example, they use some Commonwealth funded money to support the implementation of a pilot program looking at early intervention, and that's been going for the last year across 13 local health districts in New South Wales. I can certainly let you know where that's happening. I know Western Australia Health have also invested some funding into early intervention and training of therapists in this area. I could talk all day about implementing this model of care, and don't worry, Robbie, I won't do that. But I would say, please email us questions. We can certainly support you about working closely with a multidisciplinary team. As lymphedema therapists, we might know the knowledge and the importance of this model of care, but really it needs to be the responsibility of a multidisciplinary team. So we need to get our cancer surgeons, our cancer nurse specialists, oncologists, both medical and radiation oncologists on board to support allied health in delivering this model of care. And, you know, patients often feel really ripped off if they haven't been given access to this model of care these days, because it is happening across public and private settings. It's not just a private hospital or private therapist setting. It should be available to everyone. And I keep saying this, but my vision is really that all individuals at risk of lymphedema due to a cancer diagnosis should have access to this model of care. And so we need to start lobbying and advocating that wherever you have your cancer treatment, that you have access to this.
Thanks, Louise. Now, as expected, our ICG video has generated some interest, and so we might send a question to you, Associate Professor Hiroswamy. Yep. Is there a time where ICG information is limited? So if lymphedema has progressed in staging or is considered more severe, can ICG still be effective in informing personalised massage?
Yeah, thank you very much for this question. So when I started the indocyanine green at the Macquarie University in 2015, I still using a protocol which I used at the MD Anderson Cancer Center Hospital in Texas. So which one is mainly for the considering the surgical intervention. So sometimes the indocyanine green is not moving much in the advanced stage of the patient. So that's why initially I thought it might have a limitation. But after I joined to the alert team and then learn from the lot of the patient, actually the facilitative manual lymphatic drainage is going to be facilitating the indocyanine green movement and then providing a lot of the information. And then we have changed the protocol in that way. And then it's currently, so there is no limitation. So then always get some information. Even the purpose for the indocyanine green now shifted to more on the conservative management, how we can identify the drainage regions. In some cases, so we still cannot get such information, but most of the cases, especially for the upper limb lymphedema, we constantly get enough information, and then sometimes struggle with a lower limb lymphedema. But most of the cases, the indocyanine green providing good information how you can apply for your conservative management.
Thanks, Hiro. We might move into another question for you, just because it follows on quite nicely from that question. Is the ICG being used for head and neck lymphedema and breast lymphedema, as well as people with lymphedema of the arms and legs?
Yeah, thank you for another question. So my initial experience again for the head and neck lymphedema is started in Texas. And then now we've seen more of the patient. So the head and neck lymphedema is quite, the drainage route is variable. And also there is little investigated area. We definitely doing the head and neck study. And then fortunately we got a small funding now. So then now we are moving on more rigorously to obtaining more information to share to the public. As for the breast lymphedema, so we already published in the pilot study, and also set the protocol to investigate and how to investigate in the breast lymphedema. Then this also it's breast lymphedema is I think the indocyanine is quite effective, because unlike the arm and the leg lymphedema, so the volume measurement is not effective. But indocyanine green clearly see the changes of the lymphatic structure. We're definitely working on these two areas.
Thanks, Hiro. We might move on now to more of a clinical question. So perhaps Brenda, you might answer this one for us. Does lymphedema in the leg benefit from water walking?
Helps to unmute myself first. Yeah, really good question. And I must say, as a therapist, we love water. And it's actually a real frustration for a lot of people that over COVID, they haven't been able to access their usual water-based therapies, because yes, doing exercise in the water gives you buoyancy. So it's actually giving you some lovely support, but it's actually giving you resistance and turbulence as well. And of course, being in the water acts like a compression garment. So the deeper your limbs are, the more compression you have. So working in the water is a fabulous option. And if you can access it, I really encourage you to do so.
Thanks, Brenda. Another clinical question that may actually be a good one for you to answer, Louise, with your work on prospective surveillance and early intervention. How soon after axillary surgery do you suggest that patients see a lymphedema specialist?
Thanks, Robbie. There is a recommended protocol for prospective surveillance and early intervention model of care. And that protocol would ideally see someone having baseline measurements before cancer treatment. So at cancer diagnosis, whether someone's going to have surgery or chemotherapy, neoadjuvant chemotherapy, so at baseline. So we get a true indication of what's happening before any intervention for treatment for breast cancer occurs. After surgery, if you're following the protocol purely from a monitoring point of view, we would say monitor at 3 months. But I would say a big but there, because a lot of our patients come back and see the lymphedema therapist for their cancer rehabilitation. So for their musculoskeletal shoulder, improving shoulder function, scar management. And so at Macquarie, we actually invite our patients to come in at about the 3-week post-surgery time. When the drain has been removed, we would usually see someone then. So we do a measurement, LDEX measurement at each time someone would come into our clinic for treatment. But if you're following the actual formalized protocol, it would be at 3 monthly intervals. And then if someone did go to trigger for the need for early intervention, we would then probably review them at sooner timeframes.
Thanks, Louise. Dr. Mackie, we might send another question over to you. Are there any current or up and coming clinical trials in this area? I heard mention of one by Leap Cure, wondering if it's legitimate.
Yes, I'm the principal investigator for that trial, which is a drug trial, looking at early onset breast cancer lymphedema. It's an international trial. There's 4 different sites in Australia: Flinders, Bendigo, Macquarie, and southern Gold Coast, that area, and also 3 or 4 sites in America. We're about, I think we're looking towards finishing recruitment by the end of April. So if you are interested at all, get in early, get in before we finish recruitment. Yes, it's an entirely a legitimate clinical trial.
Okay, Brenda, another one for you. How do you measure the percentage difference in volume between arms when using a tape measure? Great question.
And throw me right in the deep end there.
Is the answer. We put it into a fancy computer program and it works it out for us.
We do actually, yes. So what we're doing is in our clinic, we do take measurements every 4 centimetres. So we do the circumferential measures, and we have an Excel database that actually calculates for us based on they use what they call a truncated cone. So it's like an ice cream cone with the bottom chopped off that most closely resembles the shape of a limb. And so those calculations are carried out, and it gives us a volume difference. But yes, certainly not something that I calculate for myself.
I can add there, Robbie, that there are some really simple calculators that different lymphedema therapists can access. Robin Ciola from Royal Prince Alfred Hospital has set up LympBase, which is a great software that therapists can contribute to be able to determine volume measurements for their patients. And there are some other calculators around as well. So therapists don't have to be on their own to look at these. There are lots of resources.
Thanks, Louise. So we've just had a question come through that I think we might ask Dr. Mackie to answer. And it's a really good question and something that we haven't really discussed this evening along the surgical line of things. So the question is, has any research been done on whether liposuction is an alternative treatment? And what would that treatment entail? So Helen, can you run us through the eligibility for liposuction surgery and just give a brief outline of who that might be appropriate for?
Yes, so liposuction is one of the treatments that we use for lymphedema. In the very first instance, we must say it's not a treatment for lymphedema. It's a treatment for the additional fat that can develop in an arm or a limb affected by lymphedema. So lymphedema as a chronic disease has an inflammatory component to it. And because of that inflammatory component, fat cells change and they hold their fat and they get bigger. And in all instances, the limb can build up some fat. In some people, it's a very significant amount. So what we do is we do offer a liposuction program for those people who have significant lymphedema, who have completed conservative management and are not getting any further benefit in terms of volume reduction. We then will assess them, including doing an MRI scan where we look into the tissue to make sure it is fatty and not fluidy. If it is, there's a lot of fluid there or the LDX is still very high, then we would ask the person to continue to do further conservative treatment prior to then being reassessed. The liposuction removes the fat. We put compression on intraoperatively to prevent bleeding and also to ensure that the skin retracts around the volume reduced limb, and we have a long-term protocol over at least 12 months where we continue to do compression. We move the limb from being very large, sometimes taking up to 10 litres of fat out of the lower limb in one case, and the compression garment itself becomes more effective, but we're not actually curing or treating the lymphatic lymphedema itself or the lymphatic system itself. We're removing that fat. And there are a couple of other operations that we offer at Mount Ruga, at Macquarie. These include lymphatic lymphovenous anastomosis, which is connecting lymph vessels to little veins, and also lymph node transfer. In our hands, we transfer a group of lymph nodes removed from the neck into the limb, either usually at the elbow or the knee, and this is to improve lymphatic function.
Thanks, Dr. Mackie. We might have time to squeeze one more question in before we need to wrap up proceedings for this evening. And Louise, we might ask you to answer this question. It's a really good question. What are some of the changes in MLD technique you have made since ICG and recent research?
Good. It's not too hard, Robbie. I was worried you were going to finish with a really hard question. Well, I've been working in lymphedema for over 30 years, and how I was trained to do MLD, so manual lymphatic drainage, back in the early days is very different to how I do it now. And if I do the light, very light, gentle effleurage, some people used to say stroke like you're patting a cat technique on the limb, the arm or the leg, what we found from the ICG dye and camera was that wasn't doing anything. It wasn't moving anything up the limb. So what we've learned through our research and the many of hundreds now cases that we've seen in our ICG clinic, we've termed a facilitative MLD technique. So if someone has some dermal backflow or congestion in the limb, then we need to do a much firmer, slower, directional massage technique, and depending on whether it's arm or leg, we've published data on where are the common drainage regions for that. Little plug for our therapists: if you're not aware of these latest drainage regions, then certainly come and do our Contemporary Evidence for Advanced Practitioners course that you can look on our website to find out about, to really see the clinical skills videos of how we're demonstrating the techniques. But slow and firm is the way we recommend to do our MLD when you've got a congested area.
Okay, now unfortunately we've run out of time for this evening. We'd like to thank you all very much for joining us, and thank you so much for all of those great questions. We do apologise if we haven't been able to answer your question, but we will be collating the rest of the questions that we didn't get to and circulating answers for those in the next couple of weeks. So do keep an eye out if you have an unanswered question from this evening. So thanks again to everybody for joining us. Thank you to all our presenters, and we look forward to welcoming you at our next alert event. Thank you and good night.
Thank you.